very, very important steps. The last but not the least.
Truly, the last but not the least.
Yes, sir. So we only 8 people right now. We can wait till 8:05.
No, I think we should start. The retinal guys are on now. They started around 7. Okay, it was advertised 7. I don't know when they started. So
okay.
I sent the link to 10 Teachers YouTube. So every discussion we've had so far is on the YouTube. So anybody can actually access it. So
all right.
I think another thing I noticed was about 38 have
filled the Google Forms.
Yes, the Google Form. I think we should have more people, so it could be representative of what we have done. If you report 38 responses, can it be generalized to represent the ideas of 80 participants? So that one will not be making a hasty conclusion. It's just scientific.
I think more people should still fill the forms.
Okay, another thing I noticed also is Ramadan is tomorrow. And I've lived in the north, I've lived in the west. I know how evening of Ramadan used to look like. So I don't know if 8 p.m. will be convenient for everybody here. We can take a vote now to reschedule.
People will be at the most. 8
p.m. My Muslim friends will not be available. That much I know.
Yes, sir.
And it's unfair to deny them their rights because of lectures. Please. I think we should take a vote on this. Let's think about it. Hoping to take decision later in the evening. Please confirm my audio. I'm having background feedback I don't like. Is my audio clear?
The audio is fine, but not as clear. It's clear.
Okay. Because it's being recorded, so we can have good record. Okay, if you give me permission, I think we should start.
Sir, we are good to go. We can start, sir.
All right, thank you. Let me share my screen. I still do not like the feedback. I'm having a noisy background. Please help me check. Help me check if anybody's system is on. I have good network system here. My network is on and strong enough. Okay. Another way to get the feedback is the person that is recording on the other side. I'm saying note taker. If he or she could play back a little clip and see if what has been recorded so far is clear. All right, without further ado, I would like to share my screen, please. Thank you, everybody. Where is my 10 teachers? All right. So this is 10 teachers. Today we'll be discussing Cortex, management of the Cortex, and IOL implantation. And there's a reason why most people group the discussion on Cortex management alongside discussion of IOL implantation. The reason is this: you may choose to do a complete washout of your Cortex and implant IOL later. Or if you foresee any challenges, you may have to consider putting the IOL in the first place, form a scaffold or a barrier protection for the posterior capsule before completing the IOL, the Cortex washout. That is why most people group Cortex management plus IOL implant together. Now, I have also found it necessary to group it that way from my experiences. I didn't choose it, but reviewing my videos, I discovered that some cases I will put IOL complete after Cortex washout, while in some cases I put a scaffold that is a barrier protection of the posterior capsule before completing a Cortex washout. So please, let's look at this all together. Thank you, everybody. Okay. First step in cortex management is repressurize the eyeball. Repressurize the eyeball. If the eyeball is repressurized, two things will happen. The bag will be refilled. When the capsular bag is refilled, it balloons out. My system tells me somebody is waiting for permission from host to record, please. When the visco is in the bag, it balloons the bag out and confirms that there's no posterior capsular tear. If the bag is filled up, the bag balloons out. You will notice as the bag is filled out that it will reflux out of the bag. You will notice the wave of the cortex come a little above, just a wave like a flower petal opening up on itself. That's how it will just wave up above. Reason is this: it's indicative that the bag is intact. That means the bag has not been lost. And it will highlight more of the capsular rim. One needs to have good view of the capsular rim to do a thorough cortical washout. And the third advantage of filling the anterior chamber is introduction of your instrument. Now look at it this way. In SICS, the main port, this is the main incision, is wide. This is 6 to 8 millimeters long. If it were phaco, you're only dealing with 1.9 millimeter side port maximum, 1.9 millimeter side port maximum. So introduction of instrument, if you introduce instrument through your main port, you are going to use bolus volume of visco. So when visco is lost in that quantity, the bag comes in view and it might get in view and get punctured. So it's advisable to repressurize the eyeball enough, aiming down to the bag, make sure the bag is filled up, make sure the capsular margin is seen, and preferably go to the side port. Preferably go to the side port. Okay. Your instrument of choice is okay. You could use Simco. I am the Simco type. Before, bimanual was my mainstay, but I discovered that the aspiration part of the bimanual will always block first, leaving you with multiple irrigation cannula, which does not help. So I had to contact Mohanta Pradeep and ask for his help. He told me to go to Simco. That's how I stayed on Simco. Meanwhile, disclosure, Mohanta Pradeep is one of my fellow mentors, 10 teachers mentors. It's okay. So in the next video, we'll talk about steps. But let's watch this video and see what happened here. If you can watch carefully, please help me watch carefully. I want you to look out for wrinkling. Wrinkling anywhere. Any wrinkling, stop. Any wrinkling, please stop. If the eye wrinkles, before you start asking from where is this wrinkling coming from, please pause first and stop. Okay. God willing, we'll come back to this video. We'll use another video to explain the wrinkling I mean. So this video has shown us two things. Number one, position and repressurize the eyeball. Number two, instrument of choice. Number three, preferably go through the side port. You will lose less visco through the side ports. So get your intraocular lens in place. All right. To do a good IOL implantation by default and by biometry should be in the bag. Biometry was estimated to have the IOL in the bag. So any other position of the IOL that is not in the bag is, as it were, how will I put it here now? That is not right. Of course, it could be the only measure we have, but that doesn't make it right. That means every reason to protect the bag should be taken. I never knew this until I saw one professor taking 2 hours just to reposition a capsule. Really, I was like, Prof, if it were Nigeria, uh, this capsule should have been in the drain bag by now. But the old man took nearly 2 hours just to fix up a capsule. And that was how I got to, he dropped on the argument that IOL is still far better in the bag compared to any other location. So let us say it's a compromise to put the IOL in the sulcus. It's a compromise to put the IOL, chlorine it on the iris. It's a compromise to put to fixate the IOL against the sclera. If need be, please put back in the bag. To start IOL implantation, the best thing to do is to make sure you have adequate volume in the anterior chamber and in the bag. How do you get adequate volume and adequate pressurization? Viscoelastic in the bag, let it reflux out into the anterior chamber. And while introducing the IOL, please have minimal loss as possible. How do you achieve minimal loss of the intraocular lens? I'm sorry, of visco from the anterior chamber. Every maneuver should be done externally. And with the trailing haptic in view, you can nudge it to the bag. Let's see, one video will explain what I just said now. Introduce the leading haptic. Visco comes out, no problem. Exchange your hand outside. Pick up the trailing haptic outside so that the wound is not open yet beyond that to accommodate the IOL. Leading haptic goes into the bag. Now slide in the trailing haptic here. Guide it to the bag yourself. Drop it. It enters the bag with minimal loss of visco. So the bag is still formed now. And the chamber is still formed. But then, because I have to be sure everything is in the bag, both leading and trailing haptics and the optics, everything should be in the bag. So I will still have to go back, repressurize the anterior chamber with viscoelastic solution. And after that, take a SICS hook and dive. Sometimes you might have to lift the, how do I put it now? The iris to look underneath and be sure it's in the bag. Now I'm seeing the capsular rim overlapping the IOL. That also implies that these 6mm optics is overlapped in part by a flap of capsule. That gives me an idea that my rexis was plus or minus 5.5, but at least surely less than 6mm of rexis. To confirm where the haptics are located, please always confirm. I like that confirmation. Okay. And I'm sure both leading and trailing haptics are in the back. So I'm done. The next thing is to clean up the viscoelastic solution. Use side pots if it is convenient. At this point, I use my constricting agent. In my area of practice, I don't have the luxury of having Myocor at my disposal anytime I want it. But I always have pilocarpine. So I use pilocarpine, 1 ml of any percentage of pilocarpine, dilute it with 9 ml of saline. So I use it to counter the motion in and out, and the visco comes out. Now, viscoelastic solution is still a solution in the anterior chamber. If you leave viscoelastic solution, it's going to take close to 1 week minimum, up to 2 weeks to be reabsorbed into the eye. Dispersive visco will be absorbed faster, cohesive visco less often. So in this case, this is why somebody can advise you to place the patient on glaucoma medications for the first 1 week or first 2 weeks, because it's not every time that you have the luxury of going underneath the IOL to wash off, especially if you are starting your career in cataract surgery. If you didn't wash off completely, it's okay. It happens also. Sometimes I don't wash off completely. If you find yourself not washing off completely, get saline or get any fluid and do a counter fluid motion while you are directing fluid towards 6 o'clock position. Whatever visco is on the gum on the endothelium and some on the IOL will start coming out. Now, I was taught something by Professor Jalal Ahmed in Bangladesh. If you're not so confident in going beneath the IOL, or it's practically impossible, you can use your Simco, press at 6 o'clock position of the IOL, it will depress or tilt. When it tilts, fluid will go under that tilting or depression and have a counter fluid wave underneath the IOL, while some of the visco will come out this way. When you are done adequate counter motion this other way, you come towards 12 o'clock position and tilt it again. When you tilt it downwards, fluid only, don't engage in the absorption. Fluid only will enter underneath the underneath the IOL through this other tilting on the 12 o'clock position, and fluid and visco, some will come out. If you're lucky and you tilt and counter irrigate for a longer period of time, you might actually have very little. Well, obviously, you cannot have no visco left. Then my take is this, which was what I was taught, is if I find myself in a scenario, I do not wash off all the IOLs, please put the patient on glaucoma medications for the first 2 weeks. After then, all the visco would have been absorbed out of the eyes. Okay. So I'm still doing counter fluid irrigation. And make sure the eyeball is firm, just firm. Initially, I used to like very well-reformed anterior chamber before I close up. It's not always an advantage. Of course, for those that remove plaster after 2 hours, where you need a adequate depth anterior chamber for good vision. So you can make it very firm. But if you're going to remove your plaster the next day, or you wait like 6 to 8 hours, by then aqueous will have started reforming by itself. Remember, the tunnel length is enough to protect the eyeball from any fluid going out. So that's enough time for the visco, for aqueous to reform back. Now I want us to watch something here. This is a bulky cortex underneath the capsule, and I cannot access the capsule so easily. Why? Somebody will ask me, why don't you just come somewhere here and access the capsule, or go to the side port and access the capsule? Yes, you're right. I could have done that. But look at it this way. This was a Rexis that gave us challenge. We don't have Rexis advantage this other side, the temporal side. Rather, we have Rexis advantage only on the medial side. So I have a policy. I don't know for other people. I avoid aggressive aspiration when my instrument is in front of the open posterior capsule. It's a policy I have. I don't know why I'm still scared about it up to now. I think it's healthy sometimes to be scared. So I am scared of going after such things. Now, watch what happens here, because it has happened to so many surgeons and they're not even aware. This is where I said sometimes you just have to leave that little nuisance called cortex here and little nuisance here until you protect the posterior capsule. Remember, there is no capsule advantage temporally. We only have capsule advantage medially. So there is no wisdom being brave in this eye. Again, IOL is coming up. Rule number one, make sure visco is there enough. The bag is so stretched out and I can see the capsular margin. This is what I was trying to describe. Because of this capsular disadvantage, I will not anchor my haptic here. It has to be 6 o'clock and 12 o'clock position. So let's see how this is done. Avoid loss of visco. Because I'm not going to anchor it here, I'll just throw it in and leave it. Watch how what I do now. It's in the bag, fine. Then I come out again, flap it down, and slide in. Great. All right. Instead of putting it to 3 o'clock position, you see me putting it at 12 o'clock position. I did not dial my hand to put it at 3 o'clock position. This is what I would have done if I had capsule advantage 360. Unfortunately, during Rexis, I lost some of the capsule. These are the decisions I'm taking to complete this surgery. Back to what we said. The best 2 steps of SICS is the incision length and tunnel length are the 2 parts of the incision that are so important. Incision length and the tunnel length. Now this, I got the incision length right. I got my tunnel length of almost 3 millimeters. I'm okay with that. Now the next step of cataract surgery that's so important is the capsulorhexis. These two make the journey of the rest of the cataract surgery easy or effortless. So you could see I've dialed the haptic towards 6 o'clock position and 12 o'clock position because by my judgment in the theater, I thought I have advantage here. There's a capsule I can see and I think here can accommodate it. That's how I made my judgments. Again, cortex washout is safer to go through the side port. Okay, sorry, but that's exactly how I finished the surgery. Better to go to the side port because you lose less fluid and less content at each one time. If you are aspirating through the main port, which is 6 millimeter to 8 millimeter wide, you are likely going to be having bolus loss of fluid, and it's not always an advantage, you know. If I remember this case, the iris was constricting on us, and what we did was to rock on the iris, sorry, on the cortex. No. We lost advantage of cortex, of capsule around 12 o'clock position. I think there was capsular disadvantage. I can see capsular advantage at 6 o'clock position. So that is why I'm not aspirating. I'm using fluid wave to bring out this white cortex. I'm not aspirating on purpose because I don't have capsular advantage. What will happen now? A mistake I made here, which most people do, watch, good, watch. All right. If anybody guess what just happened now, I'll give out a gift. If I meet you in OSN Kano, I'll give you a capsular forceps free of charge. All right. I'm going back again. I want someone to help me identify what just happened here. Watch. All right. Watch. All right. I've seen so many of my colleagues have this problem. And the funny part is this. Everything is called pseudophakic bullous keratopathy. But then this has a name. And this is so common. So let me pause and see those who win a free capsulosis faucet from me in Kano OSN. What just happened now? Oh God. Someone said I aspirated the capsular bag. Another person said destin membrane peel. Another person said I aspirated the PC. Well, I want more replies. Downward movement of cortical matter. Okay. You, as evidenced by wrinkling of the PC. Someone said cortical matter drop. Okay. So, okay, Kano OSN, I have my money back in my pocket. Who wants to get a free capsulosis faucet from me in Kano OSN? Someone said wrinkling of the PC. Someone said inferior rent of the PC. If there's rent of the PC, someone said cortical matter drop. Let me replay it again. Let's just say we started this way. We started this way. Carefully watch, please. Number one, everything I was doing here was to confirm safety of the capsular bag. And I was not aspirating. I was just making sure the cortex was mobile. Okay. Finally got that the capsule was safe. So I'm using fluid wave only to escort the cortex out. Trust me, no part of surgery is easy. So when next you hear someone does SICS 3 minutes, just pause and smile. Wish the person good luck, okay? What you want is finish surgery so that nobody will call you the next day for complications. Now let's watch this drama unfolding here. Watch again, watch again, watch again, watch again. I saw it and I stopped. I saw it and I stopped. It almost happened again and I stopped. And something came back to position. That is the descent membrane. Look at it this way. I was now trying to help the floating cortex since it was out of the bag, the phonetics of the bag. It then came up and was floating above the iris. I now engaged on aspiration. I was on aspiration as I was coming out and mistakenly continued on aspiration as I was going back in. That's how I caught the descent membrane. But if you get it to your microscope, if you get used to tuning your microscope to clear vision, the right oculars, left oculars, so that you can have crystal clear vision. Not one ocular is seeing better than the other. You will see a flap going about. Can I have a confession here? As a resident, I saw multitude of flaps, but I never knew what they were. As a resident, in fact, before I converted to phaco, I used to see so many flaps. Still, I never knew what they were. So if probably we give out a question, yeah, how common is descent membrane peel? I have a feeling that we might get a response that is not commensurate to the actual descent membrane peel because we commonly use the terminology pseudophakic bullous keratopathy. But that is what that can lead to that when you peel off the whole descent membrane. Okay. Watch again. With this now, it will be safe to say, in the event of engaging in aspiration, there is no need to engage in aspiration from outside inwards. When you get underneath the particle you want to pick out, then engage in aspiration. For those who have done some theory on phaco-dynamics, you can appreciate what I am saying. Before you engage on foot pedal 2, you will advance on foot pedal 1 and get so close to what you want to pick out. Engage on slight foot pedal 2, it will come to you. Then you now decide what to do next. That's what happened to me here. That's it. I was on aspiration going in, pick the capsule. I stopped. I took it back to where it's supposed to be. But release aspiration. That's the apprehension that comes in. Forgive me, I'm still a human being. I have adrenaline that surges me sometimes. But that doesn't mean I should now allow the tension in my body to affect the surgery I'm doing. So you now see, how did I solve it? I relieved an aspiration. Remember on this one. I just relieved aspiration and the whole speed stopped. Okay. So that means in Kano, I'll have my Bature. Thank you for helping me here. I have my capsular process back. All right. Kano OSN, nobody is taking capsular process from me for now. Let's go to the next cleanup. IOL, the same way. All right. Minimal loss of IOL, visco. Drop it. That's it. So let's look at how we clean here. So in this case, I've not done cortical washout. This is what I was trying to say. Sometimes it happens. Now, why? Let me go back a little, please. Watch. Let me show this very well. Can anybody help me decode what this is? This is a wrinkling. Please give me thumbs up if you are seeing where my cursor is moving, the wrinkling. If you are seeing what I'm doing, give me some thumbs up, please. Oh yeah, Otam, thank you. That video stopped abruptly. The continuation of that video ended up with air bubble. In fact, air bubble is like standard for me when I'm doing SICS because of number one, most patients that do standard SICS are elderly with low endothelial cell count. And if I notice that this person may not cooperate, I just put little air bubbles. So it's standard for me. If I do 3 cases of SICS, I must surely put air bubbles in all 3. But look at this for me, please. This started with rexes. I noticed this wrinkling with rexes. I dodged the nucleus, and now this challenge is still facing me in IOL implant. So let's see how I avoided this. First of all, how to avoid this is repressurize the bag. The bag full will show you with a stretched and very crystal clear posterior capsule. If it's wrinkled, something is still wrong. With this, something is still wrong. Capsular advantage, I can see the capsular rim this other way immediately, but I'm looking for it laterally. I'm in trouble here. So let's see what happens here. I guess that was why I avoided doing cortex washout. You see how I'm going through the sulcus. Wow. Wow. All right. First thing itself, you could still see that this wrinkling is now central. That tells you it was the posterior capsule. That means that a zonular weakness on one side. The zonals are weak on this side. So everything to be done here has to be extremely cautious. Will this wrinkle disappear? It should disappear. Ideally, you shouldn't leave wrinkle as you are closing up the eye. Then what will I do? I can't see any capsular advantage on this other side. I can't even go and, let me say, put capsular tension ring. I don't know if it will just pop out somewhere else. And A segment is totally unnecessary. So now that is me putting in the sulcus. Like I said, sulcus is a maneuver that is, as it were, your last option. So this is me avoiding the capsular bag. I don't know what this is. It's scary. But you can bear me witness. This is scary. So I have to put this in the sulcus. Thank God there is foldable IOLs that can go for the sulcus. And look at it this way. I'm carefully avoiding using Simco. Nothing is coming out by force. Whatever cannot come out under fluid counter motion. I'm sure the last time I checked, there's still steroid in it that can do the job. And there is an instrument that is millions of naira called yag laser machine. So I'll yag the eye post-operatively. So any cortical matter or soft lens matter left in there, please, it will dissolve by itself. Now, this scenario may likely be seen by most of us. My opinion is this: whatever judgment that is safety guided, please follow it. All right, so this is where I can never leave it without a PI. PIs are done. I don't know if people are seeing. This is obstructing my view. Okay. I have a way of doing my PIs. Just a tiny PI. Okay. To me, that's enough. I just go in and open it up. Make sure I pass the stroma, and then that is it. Just a tiny opening. Before I would have made my PI, it's become so large. No, but a tiny PI, as long as aqueous is flowing through, it's safe enough. Okay. So deepen. Go to the PI, make sure it's patent. Fine, beautiful, leave it alone. You could see cortex there. Forgive me, I'm done. All right. Thank you, everybody. So this is my mainstay of finishing my SICS. I must always put air bubbles. Again, visco, visco, visco. Two things you want to achieve. You want to be sure that the bag is intact. The bag will balloon out, stretch out. Visco will pour out like a flower petal opening up, so you can now see the cortex. Then you now see, most importantly, the rim of the capsule. All right. Okay. Minimize loss of visco, please. And if in the event that you notice visco has been lost, please, you can pause at this point and repressurize. It's not safe trying to tug on the capsule. If I did intraocular manipulations without visco, it's not always safe. If you remember this, I remember I had a problem with the iris. So this was a case of floppy iris. So it can occur. Now, like I had mentioned earlier, the teaching is simple and straightforward. If you find yourself in a position where you cannot go underneath the IOL to wash off all the visco, no problem. The visco will dissolve by itself within 2 weeks maximum. But then commence the patient on glaucoma medications, topical. There is no need packing the patient with diamonds. Of course, if you choose to start those diamonds, fine, it's okay. But let's be practical about it. Every cortex should come out. Every visco should come out. But there are scenarios where it is impracticable for an inexperienced surgeon to wash off every cortex, for an inexperienced surgeon to wash off every visco. Sometimes it's impracticable. But what is practicable is you can drop in some timolol morning and night until the first 2 weeks. If you can drag it to the first 1 month, it's okay, it's safe. Just explain to the patient what you're doing. Everybody will understand. I still believe it is safer to start using double side pods. Almost all our careers, especially our younger, the residents now, I do not expect any resident to finish residency and be doing SICS, because then FECO will be the minimum thing. Now, there is a discussion going on now. I don't know how many of us are privy to it. They are arguing about using laser to fragment the whole IOL, the whole lens, and aspirate it through a 3mm rexis. People are wondering why you'll be doing 6mm and 5mm rexis if the lens is already fragmented and only aspirated. So we might wake up 2030 and be doing FECO by 3mm rexis. Let that time come first. All right, so let's see what happens here. This is a practical scenario. I had these 3 today. So let me discuss what I did today. I had this kind of scenario. One was very big, very obese human being. So with each breathe in, everything looks as though it's about coming out. But because of my tunnel length, they will just anchor underneath the cornea. That is fine. Now, when I now went in to do this cleanup, first of all, depressurize, push the bag, iris downwards. You don't know, I don't have clear vision of the iris and capsule within my view at 12 o'clock position, plus or minus 2 clock hours equidistant. I don't have any clear view of what is going on in the capsule and the bag. So what I do is not to start depressing the sclera at this point. Number one thing I do is to go in, move every soft lens matter to one side, have a clear view of my bag. If by my judgment my bag is safe, then I can now start depressing the sclera. If by my judgment my bag is not safe, this is where sometimes you are advised to use spatula through the side port and reposition the iris. If sometimes you are advised to even start constricting the pupils. If by your judgment, the iris is not safe, there is no need worsening the condition. There are some cases some of our colleagues do, and you see what looks like a sector iridectomy. It's not actually sector iridectomy when you look closely. It's just like the whole vitreous came out and was almost seeping out, because you could see iris entrapped in the subcortical level. So in my opinion, which would be my suggestion, whenever you find yourself trapped in this scenario, what I would suggest you do is repressurize to the side port, make sure the iris is open, and by the time you now put in your visco cannula, move the whole complex of the lens and the visco to one side and see the capsule yourself. Let me explain again. Let's watch. Move it one side. By my judgment, my bag is safe. I can now start depressing. Can you see that? If not that, I've gone to the side port to use spatula and reposition my iris, or worst case scenario, start constricting. Again, please, those that taught me surgery told me that it's okay at this moment to have your personal opinion as a surgeon. At this point, it's okay to have your own opinion. It's not about right or wrong. It's okay to be safe at this point. So don't go blaming yourself that you lost a capsule or iris got entrapped. No. The first thing you should do is to secure through. All right, look at it. Now, to avoid desmoid membrane peel, when I'm going in, I disengage from suction. Again, there are two options. Either an initial complete cortical washout or partial washout, IOL scaffolding, and then complete the washout later on. Worst case scenario, protect the capsule, inoculate the IOL, and anti-inflammatory medications will take care of the rest. That is worst case scenario. My trading haptic is out. I'm not bothered at this point. I'll go to the side port and repressurize. There's an advantage in repressurizing. It will be far easier to nudge it backwards through the side port. Going through the main port will open up more space. So my opinion is either you pick it from here and go in direct or use the SICS scale through the side port. Go to the optical haptic angle and just start it there. It's wise to confirm that if you are aiming to achieve in the bag implantation, let it be in the bag. There's no wisdom in having one haptic in the bag and another haptic in the sulcus. You will induce astigmatism. There will be a tilt, and that is the surgeon-induced astigmatism, very difficult to correct. Actually, I had to take someone back to theater. The person was operated somewhere else, and I discovered astigmatism of -8. In my slit lamp examination, I just discovered that, look, something was definitely wrong. Only for me to see the tilted IOL. I had to go back to put the IOL all in the bag. And trust me, it's a difficult maneuver to do because you have to start freeing the bag, the capsule that's gummed on itself. It's not a good thing to do. So these are the difficult rexes that we did. And I had mentioned any step you miss will follow you to the next step. Even if someone else is helping you finish up the surgery, remember, it's not going to be that easy. Again, let me make a mention about the tunnel length. Tunnel length is important because this patient is leaving you and going home. You don't know what the person is going to start using to inoculate the eyes. Those that will be putting the eye drop, you don't know if they will remember to wash their hands before doing such. So achieve adequate tunnel length. The tunnel length of 1 millimeter to me is small. If you can make it, yeah, thanks, Victor. So at each one time, have a good tunnel length. Tunnel length of 1 millimeter could just be here. It's like entering to the limbus. It's not safe because iris can come out, disco can come out. I'm sorry, aqueous can come out, no doubt. But also, contaminations can go in also. So you don't want to have endophthalmitis, please. You know, I had this unfortunate case one time. A patient of mine, good vision, First day post-op 6-6. Excellent. As he was going, something happened to the family. Wife got sick, got admitted, near death scenario. And I saw the man about 3 weeks or 1 month after that. And I have gone. It's not always a good thing to say. So anything you must do to protect the eyes, please do. So I have incision here, somewhere here, probably 2 millimeters as envisaged, and tunnel length of about 3.5 millimeters. Now, this is one scenario where I am now putting the IOL to form IOL scaffold. Remember, we had a capsular disadvantage. And someone asked a question about calcified um, capsule. Calcification of the capsule is the least of the problem. Calcified capsule is a pointer that there could be other things wrong with that capsule, including the zonals. So if by your judgment, these zonals are weak, my advice and suggestion is do the much you can to leave the eye safe enough for you to continue next time or for another person to continue next time. Don't be in a hurry to finish up. Okay. I think it's safe to say at this moment that cortex washout is not easy. Just like incision is not easy, just like capsulorhexis is adjudged to be difficult, let me put up my own proposition that cortex management itself is not easy. I think we should know that there's something called foldable IOLs, hydrophobic IOLs, yellow IOLs, multifocal IOLs. I have a feeling we should start letting our patients know about the options. Rigid IOLs are not always the best. Trust me. If you know how comfortable a yellow hydrophobic IOL look feels like in the eye, it's just extra money, and most of our patients can afford it. So with this now, I'm feeling like I'm being filthy again. So I have a scaffold. The posterior capsule is protected in this case. If you now give me aspiration rate of 50, I don't mind. Whatever you give me now, I feel the posterior capsule is safe. So to finish up this, I don't think there will be need to put air bubble in this because the chamber looks like it's self-sealing. Let's go to another part of the, let's look at this. If you can remember this case, that was the case I was nudging the nucleus. I like the unforgiving component part. Unforgiving, not because the patient will forgive you or not forgive you, but you will not forgive yourself. Each time you have another eye to operate, your mind will jump. And that's not what you need, the eye, the eye. So this is another case of floppy iris. But the funny part is this iris cannot come out. Reason being that the tunnel length won't let it. The tunnel length somewhere here. So it is beyond the root of the iris. That is what I mean. The distance from here to this place, the tunnel length. Because I made it about 3 millimeters or a little beyond that, the textbook envisages 3 millimeters tunnel length. That's why it is said up to 2 millimeters before the nimbus and 1 millimeter into clear cornea or 1.5 millimeter into clear cornea. So that is approximately 3 millimeters tunnel length. You can do 3.5 millimeters. But please let it be your judgment based on what you're seeing on table. And like I will always say, any decision my residents make on table based on safety, I accept. If it's not okay by me, I'll go back and correct it, knowing that one day they'll be better than me. Okay, let's just finish this and see. It's difficult to have. Okay, let me put the RL back again. The IOL is going nowhere, nowhere in particular. Reason is that from day one, I couldn't see the iris margin. This man is diabetic and poorly dilating pupils. So everything was just a blind maneuver. I think there was a time I saw the capsule, but then it did have been done. So I left it in the circus. And because the rigid IOL has 6 degrees optical haptic angle, so you can actually put a rigid IOL in the circus. There are newer foldable IOLs that have a 5 degrees optical haptic angle. That alone, you can put those ones. In fact, the paper will write circus compliant foldable IOLs. So I saw those ones by chance. I've not been able to lay my hands on them. So I'm trying to do this, and this all I'll do, put air bubbles after that, and it is done. Because of the tunnel length, it will be difficult to have iris prolapse, especially if in these elderly people. Most of my patients for SICS are elderly with musculoskeletal problems. Those are judged to have poor endothelial count. I guess that's why I have fewer videos on SICS compared to FECO. Okay, I think we can look at another one. The rule of thumb in FECO is this. When you are emulsifying the nucleus and the fragments are shattering everywhere, something is wrong. As they shatter, they are hitting the endothelium. So if I should borrow that rule of thumb and come to SICS, avoid instruments flapping haphazardly. It might confuse you. Repressurize and deliver the cortex. If by your judgment you need to put a protective barrier, please put. Okay, let's check another one and see. engage on the capsule, the cortex. And any cortex on the floor is a trap. The cortex you should engage is the cortex just underneath the rhexis margin. Any cortex on the floor, do not aspirate. Engage on the polishing mode. Any cortex on the floor, please engage on polishing mode. Remove from iron A1. Any cortex on the floor is a trap. Don't use irrigation and aspiration for cortex on it. Any cortex on the floor, you want to pick it out, engage on polishing mode. That means aspiration is so minimal, practically close to zero. All they're using is irrigation and you're nudging on that cortex until it becomes free floating and you can absorb it by yourself. Cortex on the floor is a trap. Like Alcon. Like Alcon keratones. Alcon keratones are excellent. In fact, there are actually some keratones, you wonder where they are manufactured. They give you faulty judgment. Okay. Someone will be asking why I left this iris that is trapped in the side port. I left it because it's giving me view of my capsule. After which I'll just push it back in. Okay. Just operate on a patient that's having hiccup on table. You'll appreciate what I mean. Nobody will tell you to stop. So not all of my patients are for SICS. My patients that go for SICS are people I have judged to have poor endothelial cell count. If not, I'm doing phaco for everybody. So you can imagine a grandma, a grandpa on table telling you, my son, my neck is paining me, my waist is paining me. What will you do? So you have to be fast and come out. And I guess I'm not alone in having such challenges while in the middle of phaco, where patient starts acting up. Now, if that happens to you, okay, look at what I'm doing. I'm doing that tilting. That was what Professor Jala Ahmed taught me. In the event where you cannot go underneath the iris, just tilt. Please, can I show that again if you don't mind, please? Let me show that tilting again. I tried describing it, but this is the best way. Tilt, tilt again. Now, deliberately go back and tilt very soon. All right. Let me show the tilting again. This is tilting. I couldn't go posteriorly. That's the tilting. Tilting, tilting, while releasing fluid. It will help you get some of the visco out underneath the IOL. Okay. Okay, let's discuss this later as we finish this. Okay, this is almost over. Okay. I have two questions to ask after this. Since Saturday, we've been discussing SICS, and I can only ask, I can only but ask if this has helped someone directly, indirectly, 1%, 10%. I think I need that feedback for my morale sake. Then number one is call to action. What is our call to action from this? What shall we say? Rising up from this meeting should be our call to action. With the permission, I'd like to pause here. Thank you, everybody. We've done from institution, we've gone to Cortex and IOL, and then done some part of wound closure. A minute, please. Apologies, please. I have to secure my license. So I want to ask a question. Number one, let's just say on a scale of 1 to 10, has this been helpful, please? On a scale of 1 to 10, could you rate this? Wow, it's a lie. How can it be 10 over 10? It's a lie. Out of not being helped here. Otam, rate me. Since Saturday, we've been discussing this. On a scale of 1 to 10, how shall we say this has assisted, even if it's in part? All right. Now, my question is, you know, our teachers expect us to be better because, thank you. Our teachers expect us to be better. Let me say this. It's always a joy for our teachers to see us getting better. I can tell you that for free. It's always a joy for our teachers to see us discussing academics. It makes the job on them easier. So my question is, what is our call to action? What's our call to action rising from these 10 teachers? Number one, if I might start it up, I would say let everybody own a wet lab in your house. Let everybody own a wet lab. That's my own call to action. I don't know if you have any other call to action you think we should go from here. Then let's do that. Okay, maybe another call to action is this should never stop. 10 teachers will never stop. Tomorrow you will be at the icing on the cake. Of course, tomorrow we're supposed to discuss tomorrow the timing because Muslim brothers will be doing Ramadan by 8 p.m. is definitely not a good time for them. So it will be unfair to expect us to have 8 p.m. discussion. Either we move it in time to 4 p.m. or 5 p.m., which would not be good for me because I'll still be in clinic, or we do it on Sunday by 3 p.m. Please let it be our also call to action. The next thing we're going to discuss is the crux of 10 teachers, which is video editing, surgical video editing. We'll discuss it live. All right. So call to action is more 10 teachers, I'm correct? More 10 teachers. Any other call to action, please? Wet labs at home? Yes, that is my personal. Access to bionic eyes. Can I say this? Bionic eyes, they are beautiful. I must admit that, but they cost. The Indian bionic eyes are okay, but their texture and consistency in phaco is not as good as the European one, which is more expensive. So, and though some people advocate use tomato to do your rexes, use onion peel. I, for one, have a bias. When I'm doing incision, I need to see something that looks like a limbus for my measurement sake. If I'm doing tunneling, I need to see something like mimic something like early intracameral entrance. I need to see something like a side port. I need to see something that looks like a pupil I can dilate or a capsule I can stain. I still believe animal eye for now in Nigeria is better and safer. Yes, we can have simulators if the colleges or the funding agencies help us acquire. Most of our institutions are still struggling to give us adjustable tables and adjustable seats. Most of the institutions don't have microscopes with teaching aids. So asking them for simulators, that might come in God knows the budget of the federation. But then you can have something like your trial frame with your lenses for magnification. That's all that you need. And you have adequate light source. So you can have your own wet labs. Someone asked me, why personal wet labs? Why don't we advocate for um, more use of the institutional wet labs? My institution, we have our wet labs, but each time another resident is going in there, all the cannulas are blocked. The last person that used the wet labs did not flush out the cannulas. So we'll start looking for cannulas everywhere. So somebody uses and doesn't clean up this instrument properly. It come back the next day, it's becoming rusty. Yes, it's good to have the institutional wet labs, which every institution, I guess, we all have. But there's nothing like your own. You can clean up your instrument and protect it better. You can have your own trypan blue, dilute it, use one bottle of trypan blue and use it on 20 animal eyes. You can manage your resources yourself. That's my opinion about it. And can I just say this? The next 10 teachers in partnership with Young Ophthalmology Forum will be on trabeculectomy. Because of the Ramadan, I think we might have to shift our time to morning time, 7 to 8 or 8 to 9. I will harmonize that with battery and we maximize this environment of World Glaucoma Week to see if we can fix in a 1 week tutorial on trabeculectomy. What will give me the greatest joy is if you have animal eyes in your room. As we discuss, you are cutting. If you tell us to pause, hold on, hold on, hold on, hold on. What did you say about incision? I am on an eye with my crescent. I will tell you, please. Let's do it for you. We can even beam a camera in your private wet labs and then get it sorted out. No. Goat eye is the closest. Goat eye. And Nama eye, get ready for tough capsule. But if you conquer Nama eye, always calm down first before you go to human eye, because if you use the tension of Nama eye to human eye, you will tear the capsule upside down. So, but if we have animal, let's say Nama eye, you can make almost 6 trabeculectomy incisions and tunnels and close up again. So with one Nama eye, you have done 6. Can I say this? From hindsight, our teachers and our professors will be happier to give you an eye to try on trabeculectomy if you can provide evidence you've done it on animal eyes. And one of the principles of 10 teachers is this. Anybody who wants to become your mentor, approach the person respectively and respectfully, and then discuss your desire to be mentored or tutored by the person. Being tutored by multiple people is advantageous because many people have their smartest and easier way of doing the same thing. So you learn from 10 different people and become the best part of their surgical skills. That is the only way they used to say you as a student, you become better than your teacher. Not necessarily because you are more experienced than them, but because you've acquired their own skill, you've acquired Mohanty skills, you've acquired Ahmed skills, you have acquired Pankeshe skills, and you are now reviewing everybody's work. You see, they are still doing the same thing, but this guy takes extra time. Akawa has a fault throat to fix up the pupils. So you cannot finish cataract surgery without pupilloplasty. If need be, if you are doing a cataract surgery in a coloboma patient, what will you do? Leave the coloboma, you have to do pupilloplasty. So you know, see, by the time you finish up your 10 teachers studying their work carefully,
Let's be patient. I guess he has network. Okay. Let's wait for a few minutes.
So before Dr. Anya is back, what are your suggestions regarding the timing for trabeculectomy masterclass?
sorry, I lost
Okay.
my.
Okay, it's back.
Doctor, please go ahead.
Sir, okay.
Okay. I'm really grateful for this. I give it to you. Thanks. So please, can we discuss tomorrow's lecture? I am advocating a shift of tomorrow's lecture to Sunday, 3 p.m. I don't know if I have support of the house, please. If you're in support, please give me some thumbs up, please.
Yes.
Thumbs up, thumbs up. Just write Sunday, 3 p.m. Type Sunday, 3 p.m. Sunday, 3 p.m. I'm proposing that, please. If you're in support, please. Sunday, 3 p.m. Oh, great. Great. All right. Then 10 teachers trabeculectomy. I am proposing we move it to morning hours. I don't know. Some people go for lectures in the morning. Some people go for early surgical rounds. Will it be convenient?
Morning
Because
hours, 7 to 8, 8 to 9. What time exactly are we looking at?
I will leave it to the house to choose. If it's 7 to 8,
Okay.
yes, I can make it. I don't know if others will be able to make it, just because of the Ramadan. So the next logical thing is Ramadan is over. So please, I need suggestion. I think it's agreed that tomorrow's class is scheduled to Sunday, 3 p.m. That of trabeculectomy. Can we move to morning hours or should we wait till April? It's okay. Someone says 8 to 9. 8 to 9, most residents will be needed in the office. I'll make it 7 to 8. It's just a 1 week sacrifice. Okay, morning lectures not convenient. All right, so 7 to 8 income. Or can we do like Nurat, at least that much you'll understand. Can we do our 10 teachers by 10 p.m.?
Some people would doze off while the session is on.
Well, not when it is trabeculectomy.
Well,
Okay.
10 to 11 we can talk, but
Okay. Can I leave
session
it
was
for Bature to sample opinion from the general Young Ophthalmology Forum? I am
okay.
for 7 to 8, and my normal time for 10 teachers is usually 8 p.m. to 12 midnight. So for those who want nights, we can do extended night to 9 to 10 or 10 to 11, or we could just stay 7 to 8 in the morning. Anyone is okay by me, so we can do that. I'm seeing more
Okay.
of if 9 p.m. to 10 p.m. and few of
You can do 9:30 to 10:32. It should work too.
war glaucoma week, please. Okay. You see what I feared? Residents will not be available. Oh, sorry, it's not convenient for residents. At that much I know because I expect my residents to be in the hospital. So whatever I expect from my residents, it will be unfair to expect that from another resident.
Okay.
I think we have no choice to go for 9 to 10.
9:30 to 10:30 looks better.
No, discuss that, please. So we can have a unified front. World Glaucoma Week.
Okay, sir.
All right. Then, Nurat, you know my rules. My rule is this. After the teaching on Sunday, everybody will produce their own 10 teachers for trabeculectomy. Post it on any link you want. Post it to my, locate me on Telegram. Post your own for me on Telegram. So between Sunday and the beginning of the World Glaucoma Week, which is on Monday, and that'll be our first night on trabeculectomy, do your own. That is the whole concept of 10 teachers. And here I will say, thank you, everybody. Good night, and God bless you. Till Sunday, we'll see you again.
All right. Thank you very much, sir. Been a wonderful night. Thank you all for joining in.